First of all, this session is being recorded, so please do not include any protected health information, especially during case consultations. Let's see. Also, roll call is mandatory if you need to get CNE or C certificates. So the way you can do that is announce yourself verbally over the phone, or you can type in your full name and where you're from in the chat box there, and then CEU certificates will be sent out towards the beginning of each month. If you want to join in on the conversation, if you have a video camera, we'd love to see your face. So the way to do that is to click on that video camera icon, and if you'd like to join in audio, you can do the same thing by clicking that old microphone icon. If you have groups larger than 5 people, please email your list of attendees to me, Zach Johnson. Here are our disclosure and accreditation statements. I'd like to look at those briefly. Okay, so we'll give you just a few minutes to announce yourself either by chat box or on the phone. Tell us who you are and where you're from.
Oh, my name is Sarah Sagany, and I am from Shiprock, New Mexico.
Hi, Sarah.
Welcome.
Yeah.
Anybody else out there? I see Sandra. And Sandra, I'm not going to try and pronounce your last name.
From Shiprock, she just chatted in.
Okay, I'm sorry.
Good morning, Sandra.
Okay. All right, with that, I will turn it over to our facilitator. She will introduce our speaker.
Before I do that, let's go around the room and introduce who's in the room sitting with Jen.
So Kevin Worling, Systems Analyst here at Envision, New Mexico, and I do want to introduce Zach Johnson, who just did our intros for today. He's going to be taking over Adolescent Health Initiative telehealth sessions, and so I'm just here for moral support today.
I'm Carol Conley, Education and Outreach Manager here at Envision, New Mexico.
Hi everyone, I'm Emma Clough. I'm an MSW intern here at Envision, New Mexico. I'm Andrea Anderson. I work on the LARC project here at Envision.
Hello, my name is Maya Trujillo. I am a quality improvement specialist with Envision.
I'm Jane Beckley. I'm a nurse practitioner working with the Fronteras grad at Envision, New Mexico.
Okay. Well, welcome everyone to Studio Envision and to our Adolescent Health Initiative New Mexico, where it is our goal to bring you up-to-date information and resources related to the care of teenagers. I am pleased to introduce a returning speaker. Thank you very much, Jen Robinson. Jen is a board-certified women's health nurse practitioner and a certified nurse midwife. She provides reproductive health care to adolescents at the UNM Young Children's Health Clinic, and Jen has a special interest in providing long-acting reversible contraception to adolescents and in improving healthcare access to underserved communities. Jen is currently working on a LARC project here as a partnership with Envision and Adolescent Medicine all around the state, training providers to provide this best practice care to adolescents. Thank you so much for coming back to do this talk, and welcome.
You are very welcome. Oh, Kevin, you zoomed in on me again. Okay. Good morning. Good morning. So today I'm going to be using slides that were created by the University of California, San Francisco Bixby Center for Reproductive Health. I'm really grateful to them for sharing these slides with us. And here we go. My one disclosure is that I am a trainer for Merck for providers all over New Mexico to become FDA approved to provide the Nexplanon. And what we're going to talk about today is the effectiveness, side effects, and benefits of IUDs and implants. and we're going to talk about some common misinformation shared by providers and patients about IUDs and implants. And we're also going to briefly review one case to highlight how we can use the CDC medical eligibility criteria to safely initiate and continue contraception for all women and for adolescents. So I wanted to start out by talking a little bit about reproductive justice approaches to offering LARC methods. So today I'm going to focus exclusively on LARC methods of contraception because I find that in general, patients and providers have less information about LARCs than they do about other methods. But that doesn't mean that LARC methods are best for everyone. Just because they are the most effective methods at preventing pregnancy doesn't mean that that's the best choice for everyone or what patients will choose after providing contraceptive counseling. And so it's really important to just provide all the options with correct information and let patients make their best decision for them. And I also want to point out that anytime a patient shows up to get a LARC method removed, I always like to review all of their options. If they're having a problem, let's say with breakthrough bleeding on the next one on, I always go over all of the options for treating that, in addition to saying, if you want this removed today, I will totally take this out. So we always want to make sure we're removing methods when people are requesting without providing resistance or feeling like they need to give us a good enough reason for us to take it out. It's really important that we're able to offer access to both insertion and removal services. So I will start out by talking about the copper IUD. It says up on that slide that it works for 12 years. It is FDA approved for 10 years, but many large family planning organizations like Planned Parenthood have adapted their guidelines to reflect what the research shows, which is that the Paragard can be effective for 12 years. And the UNM Family Planning Division here just updated their guidelines to reflect that extended effectiveness as well. The copper IUD is almost 100% effective, and we'll talk about the specific effectiveness rates a little bit later. And it is the only highly effective reversible non-hormonal method in the market. And does anyone know what else the copper IUD can be used for in addition to just regular contraception?
Postcoital contraception.
Yes, emergency contraception. Yes. So the copper IUD is the most effective form of emergency contraception. So emergency contraception is contraception that can be used to prevent pregnancy within 5 days after having unprotected sex. The copper IUD is almost 100% effective as emergency contraception, which is really amazing compared to the levonorgestrel emergency contraception, most commonly known as Plan B, or the ulipristal acetate, which is also known as Ella. Those emergency contraception pills are about 85% effective. The other great thing about using the copper IUD for emergency contraception is that it works better at days 4 and 5 after unprotected sex compared to the pill forms of emergency contraception. And we know that the Plan B or the levonorgestrel emergency contraception doesn't work as well for patients that weigh over 165 pounds. And the Ella doesn't work as well for patients who weigh over 195 pounds. But the copper IUD maintains this nearly 100% level of effectiveness for women of all weights. And once it's in, if a woman chooses to keep it in, it can provide ongoing contraception. And it starts working right away for that. No backup is needed, which is different from the hormonal methods of contraception. So moving on to the levonorgestrel releasing IUDs. These are IUDs that have a very small amount of progesterone hormone, do not have estrogen in them. And you can see the list of IUDs in this category are growing. The IUD manufacturers are coming out with more and more these days. You can see the list up there, and we'll go into details on the next slide on that. It's important to know that some of your patients that might come in saying, well, I can't take anything with hormones in it, might be able to take this safely because women with certain forms of hypertension, migraine with aura, other medical conditions that make estrogen contraindicated for them, are likely candidates to receive this method because it has only the progesterone hormone and it doesn't have those estrogen contraindications. There is also a range of non-contraceptive benefits with the levonorgestrel IUDs. Specifically, the Mirena is approved by the FDA for treatment of heavy menstrual bleeding. So periods become lighter in flow, shorter in duration, less frequent, and these IUDs can also help with cramping, and they can help with stopping the bleeding that could be causing anemia related to heavy menstrual bleeding. And the hormone acts locally in the uterus and doesn't go through the whole body systemically like the other hormonal methods like the implant or the pill. So this very busy chart shows us that the FDA-approved duration of effectiveness is different than what the research shows us. And the reason is when these long-acting contraception methods go to market, the manufacturers bring the research that they've done and the FDA approves based on that research. But the research continues beyond that FDA approval, and we've been finding out that they actually work for a longer duration than what the FDA has approved, which is why some of the large family planning organizations in the country are moving their guidelines to reflect what the research shows. So we talked about the Paragard being FDA approved for 10 years and the evidence-based duration being actually 12. The Mirena is approved for 5 years from the FDA. The research shows it can actually work for 7. And Loletta, there is a little adjustment to the slide that I didn't catch when I submitted it. In the past month, the Loletta has been approved for 4 years of use, and their manufacturer is continuing to go back to the FDA with the intent to be approved for 7 years one day. And the Kylena and the Skyla are the smaller levonorgestrel IUDs produced by Bayer. They are about 2 millimeters smaller on each end than the other levonorgestrel IUDs, and they have a smaller dose of the hormone, which actually leads to more frequent bleeding, can for some women. And you can see the Mirena and the Loletta, made by 2 different manufacturers, have the same total hormone dose of levonorgestrel. Their daily release is a little bit different, but we can kind of consider them to be very, very similar. And you can see that, again, that the Paragard the copper IUD has no hormones in it. So really, really, really important to know that the way that IUDs work is preventing pregnancy. You have to be pregnant to have an abortion. And so by preventing pregnancy, we can see that the IUDs are not causing abortions, which is a common misconception that your patients might be coming in to see you with. So the main way that both types of IUDs, the copper and the hormone IUD, work is by preventing fertilization, by preventing sperm and egg from meeting. The way that they do that is by preventing the sperm from being really good at swimming, changing their motility, and also decreasing the chance that sperm and egg can survive. With the levonorgestrel IUDs, they thicken the cervical mucus, much like other hormone methods, to prevent sperm from even getting up. And other research that we have that supports that IUDs prevent pregnancy and do not cause abortions by not disrupting an implanted pregnancy. They did studies with the fallopian tubes where they flushed them and found no fertilized eggs for women that had IUDs in place. And they measured the HCG hormone that women produce in pregnancy, and no women had transient elevations in that hormone in these studies that are cited in the corner there. You can look up those studies. And we know from a lot of research that IUD users have low rates of intrauterine and ectopic pregnancy. So moving on to the Nexplanon is the only implant in the United States that's FDA approved. It is a single rod, and it is placed in the arm right here. It is FDA approved for 3 years. There's good research showing that it works for 4 years, and a World Health Organization study has showed it could even work up to 5 years. I know recently the UNM Family Planning Division changed their guidelines to discuss this as working for 4 years. It's nearly 100% effective. The only pregnancies that happened in women with the implant in place were from women having sex within 2 weeks before it was put in or within 1 week after. So that makes this the most effective reversible form of contraception, and in fact, more effective than tubal ligation. But it is completely reversible, just like all of the IUDs. The way that it works is it prevents ovulation and thickens cervical mucus to prevent sperm from swimming up. Again, just like the levonorgestrel IUDs, this is a low-dose progesterone method. There's no estrogen. The question I get asked quite a bit is there effect on bone density, like with the depot, and there is not an effect on bone mineral density with this implant. One of the big differences between the Nexplanon and its predecessor, Implanon, is that the Nexplanon is radiopaque, so it can be visualized with different forms of imaging that are easier for people to access. They also changed the inserter just a little bit. And for the implant, unlike for the IUDs, providers have to go through a 2-hour-long training to be able to put the implant in. And for IUDs, there is not that same FDA required process, but there could be institutional requirements from the places where people work where they need to have a few observed to be credentialed with their organization. So a really big question and concern for providers that have used Norplant with their patients or have had patients come in that had it is Nexplanon as difficult to remove as the Norplant was? I'm very happy to report that it's just one rod and they've really changed the design to make it less sticky and it is much easier to remove than Norplant. This link that's on this slide is super, super, super important for those of you who will be removing implants, or if you work with providers who do and you want to share this with them. This video is a pop-out removal technique for removing implants, and I have found it to be super helpful. I dreaded this procedure before, and after I learned this technique, have been super, super happy with it. It makes the removals less invasive, shorter in duration, and is instrument free for the most part. So it's a 2-minute long video, and feel free to share with your other providers. So the average removal for Nexplanon takes less than 4 minutes. And I just can't say enough how helpful that video is. Oh, and I will say also with my adolescents, their biggest concern that I'm finding is that they're really worried that getting the implant in is going to hurt, and they're really worried that it's a surgery to get the implant out. So I've included that in my contraceptive counseling, that I talk about exactly what the procedure is like. Same thing for the IUD, that they're concerned that it'll be uncomfortable, and they have reason to be concerned that the IUD insertion could be uncomfortable. But for the implant, we can really go over the procedure with them, and usually see them kind of go, oh, okay. They don't totally believe me until after it's done. But and then I always make sure to say, as part of my counseling before I put the implant in, what it's like to get it taken out, and that they can have it taken out at any time for any reason, just like with the IUDs, and that seems to kind of take the weight off of them a little bit too. So you can look on YouTube and see videos of the removal, and the teenagers have often done that and come in super freaked out. It looks bloodier and scarier than it actually is, so just know that your teenage patients are probably doing some internet research that makes this look pretty scary. So something else that I really like to highlight with all patients of all ages, but especially with adolescents, is that all of these methods, the implant and the IUDs, are rapidly reversible. We've seen pregnancies in women who have had their LARCs removed from people having unprotected sex within 5 days before the LARCs were removed. That's how fast the ability to become pregnant goes back, because sperm can live in your body for 5 days. And it is really, really, really important to highlight this, because there's a lot of community memory about forms of IUDs and implants that weren't rapidly reversible. And so it's really, really important to let them know, as soon as this is out, your ability to become pregnant goes back, unless you've had something happen in the meantime that's not related to your IUD or implant that affected your fertility. So most women qualify as LARC candidates, again, because there's the copper AD that's no hormone, or the other LARC options only have progesterone, do not have estrogen. A lot of adolescents that I work with like these methods because they can be used privately, not visible, not like the mom would find a pack of pills in their room or something like that. But they do change, many of these LARC methods do change period patterns, and so that's something else to consider when you're talking with your patients about confidentiality. If they have parents who are watching to make sure they have their period every month, and then their period pattern changes, something to chat with them about before, for sure. Uh-oh, I got really excited there. Okay. So this is a chart that I use when I'm providing contraceptive counseling to my patients. You might have seen this before. This is my very favorite tool to use, and it is produced by bedsider.org, which is an online resource that I refer all of my patients to look at. If I'm running behind in the clinic, I like to pop my head in and ask my patients if they have a smartphone and tell them to go to the bedsider.org website so they can look around and kind of know more what we're going to be talking about. And I have these available in the room as well. And then the UCSF Bixby Center also co-produced this, this chart. It's available in English and Spanish. They're working in other languages too. So the reason I have this chart up now is it shows how you can talk about different types of contraception using tiered levels of effectiveness. So always we guide contraceptive counseling using the priorities for our patients. What do they identify as the most important thing? As I mentioned before, it's not always pregnancy prevention that's their #1 most important thing in choosing a method. Sometimes it's really important for them to have a period every month. Sometimes it's, I really want something to treat my cramps. So we have to guide our counseling using what's their priority, but we can always guide it using, starting with the most effective methods and then going kind of down the line and making sure we're talking about all options. So you can see with the little pregnant lady icons on the side there that the LARC methods are more effective than any other methods. And in fact, we can talk about LARC effectiveness in out of 1,000 women. This chart shows just out of 100, when in fact, only 6 out of 1,000 will become pregnant on Mirena, 8 out of 1,000 will become pregnant on Paragard in 1 year. And I had mentioned the effectiveness of Nexplanon, that no one has gotten pregnant on the Nexplanon in all of the studies that were done, unless they had sex within 2 weeks before or 1 week after it was put in. And you can see going down the line that the Depo, about 60 out of 1,000 would get pregnant in 1 year. The pill, patch, and ring, 90 out of 1,000 get pregnant in 1 year. And with people just using condoms, about 180 out of 1,000 will get pregnant in 1 year. So that's 1 in 5 for condoms will get pregnant. Most adolescents that I talk to don't know that they're not, and I always encourage them, please continue using condoms. I'm so glad that you're using them, but I always talk about the level of effectiveness, which is usually surprising. Also, they seem very surprised that the withdrawal method is not super effective. So that's always something to emphasize. It's way better than nothing, but let's talk about something else that maybe would work a little bit better. And I should like to show them where the pull-out method is on this chart. That's on the bottom. And these also come in posters that you can get and order for free using the Bixby UCSF order form that's on their website. So why is LARC so much more effective than these other methods? Well, patients don't have to go to the pharmacy on a regular basis to fill a prescription. They don't have to come into the clinic every few months or even every year for some of these methods. They don't have to come in. We love for adolescents to come in for STI testing, for the CDC guidelines, and for other reasons, but they don't have to come in regularly for contraception, which we know is a growing problem with people having more limited access to healthcare coverage and possible cost sharing that people might encounter with the pill, patch, ring, and shot, which unfortunately, though it is against what the ACA says is still happening. I love this slide because it really humanizes what it's like for any person to take a medication for any reason. We know that, and this is based on research that was done with people with chronic diseases that really needed to take their medicine on a regular basis. So we know that over 30% of people who need to take a medicine every day will miss 3 or more times in 1 month. And by the 3-month mark, over half of the people are missing 3 or more pills a day. And so this slide is awesome because it makes missing pills a human problem and a human normal kind of practice rather than a woman problem. It's not that women or adolescents are really bad at taking the pill, it's that humans are really bad at taking a daily medication. And some of these folks in this study were people who were transplant patients. And so it was kind of like a life or death thing for them to be taking their medication regularly. And it's just a hard thing for people to do. So with the LARC methods, you don't have to have a daily pill. And so that's something else just to kind of share with your patients and really keep in mind ourselves when we're talking to people, that we can really have compassion that this is a problem that a lot of people have in general with taking something every day. So in general, women really, really like their LARC methods and keep them in more than other methods that they would continue using for contraception. So I know that a lot of clinicians have expressed frustration. I felt this frustration too when someone comes in for what we would consider maybe an earlier removal than what we would like for a LARC or for an implant or an IUD. So I know that that's a common concern. I've even come under a little bit of pressure from different groups that I've worked with saying, well, we're hearing that a lot of people are coming back to get their IUDs and implants taken out. What's going on with that? And so I really like to point out, well, the research shows, what I believe is reflected in our patient population as well, that most women actually like their LARCs and continue with their methods. The reason why it might seem like they're coming back disproportionately to remove or to get them removed or stop using them is they have to see us to take their IUD or implant out. Some women can remove their IUDs on their own, but that's a tricky thing for some women, and some women don't know that. It's a matter of angles and finger length too, so it's not it's not always the easiest thing. But women have to come to us to discontinue their LARC methods, and they don't have to come to us to discontinue their other methods. And so we're seeing them more than these other folks that are discontinuing. This research that's reflected in the slide comes from a big study that was done in St. Louis called the Choice Project with 10,000 women. And so this is the one-year continuation rate. Approximately 80% of women were continuing their IUDs and implants after 1 year of having it put in, compared to, and you can see the other rates up there, around 70% for the pill and 56% for the depot shot. What's cool is we have the 3-year continuation rates coming out of the Choice Project now, and it showed that at the 3-year mark, about 70% were continuing with their LARC methods compared to 30% of people continuing the shorter acting methods. So those are the pill, patch, ring, and shot. And these rates are seen in patients of all ages. So at the 1-year mark with the Choice study, patients between 14 and 19 were continuing LARCs at 81%. So 81% of those teenagers had their LARCs in after 1 year. And they also measured satisfaction rates. And about the same percentage of women reported that they were satisfied with their LARC method. So, as I mentioned in the beginning, part of the reason this presentation is focused on LARC is not a lot of women know about it. Not a lot of providers have all the information they need to counsel patients. So in the studies that are cited here, less than half of the young women had even heard of LARC. 2/3 of the patients who did know about it didn't know really anything about their safety or effectiveness. And these young women reported that their healthcare workers and healthcare providers, are their primary source of information on contraception. So what does that mean? We have to know how to talk to them about these methods and not assume that they know. When they come in asking for the pill or they come in asking for the shot, I like to back it up and say, hey, is it okay if I go over all the methods that we have available for you here in this clinic, or all the methods that are available to you in general if you don't have LARC at your clinic? I just want everyone to know all the options that are available to them. And if after reviewing all these options, you still want to go with the pill or the shot, great. I just want you to have all the information you need. So not assuming that patients know, most patients do not know all their options. And that's not just for specialists, it's not just for women's health providers, that's for everyone, because not everyone gets to see a women's health provider. Some people see primary care specialists or primary care providers only. And so it's every provider's responsibility to talk to, especially adolescents, about all of their options, because we know that they don't have all that information on their own. All right. Oh my.
Oh, you're fine.
Am I okay?
You are fine.
Okay. So I'm going to go through a quick little case to review how to use this really helpful tool. This is the CDC medical eligibility criteria. It's available online for free. You can, I just Google CDC medical eligibility criteria every single time I need to use this resource because the CDC updates it so much that if you print out Andrea and I found this out by trying to provide this resource to residents, by the time we printed it out and laminated it, it seems like there's a different copy available online. So I always Google it, go straight to the CDC site, scroll down, and get to the chart. So it's a 2-page chart that has these colors that are guiding your decisions about how to safely initiate contraception. It's also available as an app that you can get for free. I like using the chart better, but that's another option. So the way that this works is there are a bunch of different criteria available in the chart, and so there's a list of medical conditions that could change someone's ability to safely initiate a method of contraception, and then there are 4 categories that let us know what methods are acceptable. So the green means go. So the number 1 means the method can be used without restriction, and the number 2, which is the light green, mean that the advantages usually outweigh the risks of a method for a certain medical condition. The pink, that's a 3, means really need to consult with a family planning specialist if you're going to consider that option for your patient. You can do that by calling if you're a UNM or if you're a New Mexico provider, you can call the UNM PALF line and ask to speak with a family planning specialist or reproductive health specialist. There are OBGYN physicians who have fellowship training in family planning, and they can help you talk through if you think that you want to use something that's a category 3. The category 4 is absolutely no, do not use this method. The only people that can initiate something in a category 4 would be those family planning specialists. For the rest of us, that's not something that we would really want to do. So the case study that we're going to review to see how we can use the medical eligibility criteria in our practice is this patient, Mari, 18 years old. She does not have children. She is using the birth control pill for pregnancy prevention, but she forgets to take it a lot, which we now know is a normal human behavior that a lot of people struggle with. She had pelvic inflammatory disease 2 years ago. She's having some discharge today. She thinks she might have some vaginitis. She wants to go to college before having children, and she's requesting an IUD today. So would you be able to provide the service to her today, or would you know where to refer her? And would you know if that's a safe option for her or not? Let's go through some of the things that folks might be concerned about. For those of you providers, or Andrea, what do you think are things that would be important to look at for this case that you'd want to check out to make sure it's safe to do an IUD?
I guess I'd want to clarify what her vaginitis symptoms are, and I don't have to do a wet mount or whatever, but see what's going on before you insert something.
Yeah, absolutely, vaginitis, for sure. And we'll go to a slide that shows exactly where to find that on the medical eligibility criteria. So some patients and their families come in really adamant that they don't want a teenager who's had no children to use an IUD. And some of that is based on some old concern, based on problems with the IUDs that existed in the 70s called the Outcome Shield. And so we know now with the IUDs that we have here, yes, the IUDs that are available in the United States are totally safe to use in nulliparous women. And in fact, nulliparous women love their IUDs. And it is not that different of a skill set to put IUDs in nulliparous women than multiparous women. And I'm super happy to talk to anyone who has specific questions about what I do when I'm putting IUDs in women who've never had babies, which is what I do mostly. It's not super common that I see someone who's had a baby before and put an IUD in them. So I have a lot of tricks that can help with that. Another concern is, do IUDs increase the risk of pelvic inflammatory disease or infertility? So no, they don't. There's a slight increase in risk within the first 3 weeks after putting an IUD in, but that's more related to the procedure than the actual IUD increasing the risk. And IUDs do not reduce future fertility. Again, I really, really mention that as part of my contraceptive counseling for all women, because that is a massive concern that people have. And so going back to our case, Mari, she had pelvic inflammatory disease 2 years ago. Can she still get an IUD? So she definitely can. And this picture here is a cross-section of the string that was used on the Delcon Shield, which is the IUD from the 70s that I mentioned. And you can see all those little different filaments in there, and you can see the spaces between them. So with the design of the string, which is a multi-filament string, with the Delcon Shield in the 70s, bacteria could wick up the string into the uterus and increase the risk of pelvic inflammatory disease and infection. So we figured out that was going on. The Delcon Shield had a lot of problems. It is not available anymore. And the strings that exist in the IUDs today are monofilament strings, so they don't have that same wicking problem. And so patients that express concern about like why, you know, or that, oh, I heard this, I always go over this information with them. But in general, if part of my IUD counseling is I was talking about how this doesn't increase your risk of infection. But it provides a great opportunity to talk about how condoms are still really important, really promoting that dual coverage, because even though these LARC methods are great at preventing pregnancy, they do not reduce the risk of people getting STIs. So really important to still use condoms. If someone has active pelvic inflammatory disease, which per the medical eligibility criteria is any pelvic inflammatory disease in the last 3 months, then it's considered a contraindication. You have to wait 3 months until after treating PID. It's not very common that someone comes in with PID, but we always have to know that that's a consideration. But for people that have had past PID, whether they've had a pregnancy after that PID or not, it is totally safe to put an IUD in them. So for this patient, in this case, her PID 2 years ago is not something that would prevent her from getting an IUD. And what about patients with a history of STIs? Can they use an IUD? Yes. So if someone has current chlamydia, gonorrhea, or if you put a speculum in and you see mucopurulent discharge coming from the cervix, or the cervix is really red and really angry, do not put an IUD in that person that has obvious cervicitis. And the current chlamydia or gonorrhea is if someone has had a known exposure to gonorrhea or chlamydia and they have not been treated, if they've had a positive test for gonorrhea and chlamydia and they have not been treated, or that's basically it. So it is okay to do, I'm probably ruining the surprise for one of my slides that's coming up, but it is okay to test for gonorrhea and chlamydia on the same day that a patient comes in for an IUD, and you don't need to have those results in front of you to be able to put the IUD in. But it is something that we do want to test for in case they do come back with a positive result, then we would treat them. So we're talking about patients who are coming in and we know that they've had gonorrhea or chlamydia and they haven't been treated, or we do an exam and we're like, whoa, this is not going to happen today if it's the mucopurulent discharge or the cervicitis. And then you had mentioned doing a wet mount, which is great. If someone thinks they have vaginitis and you're able to do a wet mount in clinic, and it is yeast, bacterial vaginosis, or trichomoniasis, you can still put the IUD in that day. You diagnose and treat the vaginitis on the same day that you can put the IUD in. And we really want to reduce the number of visits that someone has to be able to get their IUD in if we can put it in safely. Because we know that only about 50% of patients are going to come back for a second appointment if we have that kind of multi-appointment process to get people in. So this is a slide that I ruined the surprise that you can do same-day STI screening. Even if a patient is at high risk for gonorrhea and chlamydia, it is okay to test them the same day that they come in for their IUD and then treat them if they're positive later. And the reason for that is we know that patients are not super likely to come back if we schedule them for a second visit. And so we really, really, really want to support people where they are and honor their being present in your clinic the day for doing these. Old practice was to make sure someone was on their period the same time that they put their IUD in. That is logistically very complicated and not medically necessary. So it's okay to insert the IUD at any point in the menstrual cycle as long as you can be reasonably certain that someone isn't pregnant. So we talk with a lot of our PEDS residents that can't put in IUDs and implants in some of their clinics about bridging when you're referring a patient. If you don't have all the LARC methods available in your clinic, they want a LARC method. What can you do that same day that they come and they get the contraceptive counseling? They decide, I want that IUD or implant, but they have to wait for an appointment at another clinic. So a really helpful thing that you can do is provide pill, patch, ring, shot, condoms, emergency contraception to help them be covered in preventing pregnancy before their LARC insertion appointment. And I've had patients say, you know what, I think I'm just not going to have sex until my appointment. And to that I say, that is totally fine. Can I offer you condoms and a prescription for emergency contraception just in case something changes? Or can I send over the prescription for the pill that you're sort of interested in just in case you change your mind? So always opening the door for kind of meeting them where they're at, but offering options. Okay, if you liked this information and you want to learn even more, the University of California, San Francisco offers a free 1-hour online training that might look a lot like this, but might be a little bit different. And you can share that with anyone in your clinic. So it's designed for medical assistants, billing people, pharmacy people, front desk folks, everyone involved in your clinic flow. We really encourage them to have this correct information because sometimes patients ask everyone in the clinic flow, and we really want everyone to have the correct, accurate, updated information on what we talked about today. So please share this resource and encourage other folks in your clinical locations to go and get this training. And I'm very happy to have folks ask questions or email me their questions later. Any questions from you all or the folks online?
I have a question.
Yeah.
So I'm thinking about this as a primary care provider in rural New Mexico. And I've got a teen patient, and she is a good candidate. She's interested, and I'm not skilled in any of those. What are her options? What can that person be offered?
What can be offered for contraception, or what can be offered for referral?
For referral.
That is a really great question, and there are 3 resources that come to mind. Federally qualified health centers in New Mexico can now bill and be reimbursed for these devices. And so that's a lot of the work that Andrea and I do all over New Mexico, is helping support primary care providers in federally qualified health center networks to have these skills to be able to provide these services. And I actually, for another presentation that I'm giving at the New Mexico Nurse Practitioner Conference, if you want to learn more, I looked up, there is a way to find all of the FQHC clinics in New Mexico. And now I'm trying to think about what that website was. It's like through the MPI website. So I just Googled FQHCs in New Mexico, and it was one of the first things that came up to search where they are. I'm not saying every FQHC in New Mexico is up to speed and ready and has these devices ready to go. But it's really important to know for folks that are practicing in rural New Mexico, call your FQHC in town and see what are they offering, because we're really working to support them. And now that Medicaid has offered the ability for them to be reimbursed for the devices, that's really removed a huge barrier that previously existed to them providing the service. It's something that New Mexico should be really proud of, because we're one of the only states that's unbundled that reimbursement. So FQHCs is one. School-based health centers are another resource that I can think of, and not every school-based health center has the ability to do implants and IUDs, but they are awesome navigators if they don't offer those services, and they can be a great resource for you calling and saying, hey, I'm interested in referring for this. My practice isn't going to be able to do it, or it's going to be a while. Where do you all send people if you don't do it already? And then so the New Mexico School-Based Health Alliance, did I get the name right? Alliance for School-Based Health?
There you go. New Mexico Alliance for School-Based Health.
I think I got all the words, but maybe
We
not the
just
right
call it
order.
the Alliance.
The Alliance. So if you Google the Alliance for School-Based Health in New Mexico, there's a map, and it shows all the school-based health centers where they are, and they're a great resource too. The other resource that I can think of, which is probably the resource that's offering LARC insertion confidentially for adolescents most in the state, is the New Mexico Department of Health Family Planning clinics. And there's decreasing availability at those clinics, but they're still open, even if they're not open every day. In many communities, there's someone that comes in at least a few times a month. And so that's a really good thing to know about. There is a map of those clinics as well on the New Mexico Department of Health website. So those are the 3 resources for LARCs that I can think of in rural New Mexico.
And Primary Care Association website might be able to direct people to FQHCs.
I think that the Primary Care Association is a good resource, but they don't work with every FQHC.
Right.
And so that map that I found was like very, very comprehensive.
Okay.
But I think the Primary Care Association has some LARC-specific work that they've done, so I think they would be a good resource too. But maybe
they
not
don't map all the FQHCs.
Not that I could find.
Okay.
But I haven't gone in all the corners of that website to see.
Okay.
Yeah.
Jen, we've got a question from
Yeah.
Sandra in the chat box. The question is on the, forgive me, Nexplanon being important, but let's see. So my question is on the Nexplanon consent. There's a statement about it being important to put the Nexplanon in at the right time in a patient's menstrual cycle. Can you tell me more about that?
Yeah.
Is there, it's quite a long-winded question here.
Okay.
Can you tell me more about that? Is there any data or timing insertion on decreasing post-insertion spotting? Also, do you recommend 1 week of backup after Nexplanon insertion? And she says, and I ask this of everyone all the time, but what are your thoughts about putting in IUDs at school-based health clinics?
Oh, I can answer all those questions, and I'm excited about all of those questions too. So on the consent, you probably read the consent more in detail than I have for the Nexplanon, but I can say that it is really important to not put up additional barriers to have, like, saying someone has to come in at a certain time of their menstrual cycle. I think what that consent might be alluding to is the being reasonably certain that someone is not pregnant. And so what the Merck party line is on that is you have to be reasonably certain that someone is not pregnant when you insert an implant. And so one of the ways to be reasonably certain that someone is not pregnant is to have them be within the first 5 days of their menses. There are a lot of other ways to be reasonably certain that someone isn't pregnant. But I will also say, working with adolescents, sometimes you only get them in the clinic once. And so the Colorado folks that have done a lot of LARC work actually have a quick start Nexplanon protocol to insert the Nexplanon even when you cannot be reasonably certain that someone's pregnant, as long as you have them come back for follow-up in 2 to 3 weeks. And I have used those quick start protocols as well. And so that's sort of provider discretion and what your institution will support you in doing. There is no harm to a pregnancy if, let's say, someone was within the first, someone comes back for follow-up visit, has a positive pregnancy test with the implant in place. We know that the progesterone hormone in the implant is not going to harm a pregnancy. So that's something that kind of use your own discretion, but I believe it's just referring to being reasonably certain someone isn't pregnant, which you can get to the CDC kind of guidelines for that. And it's also a World Health Organization standard by just Googling CDC, how to be reasonably certain someone isn't pregnant. As far as decreasing the post-insertion spotting, I wish there were like a magic bullet or like, oh, it's just insert on day 13 of the cycle and it's fine. But unfortunately, there's just no way to predict who's going to be your bleeder on the next one on. And we know about most women have shorter, lighter, and less frequent menses on the implant. But 1 out of 5 is going to have amenorrhea, which most women like, but not all. 1 out of 5 is going to have that frequent spotting. It's not heavy. It's not heavy enough to cause anemia, but it is really annoying to a lot of women. And I have not ever seen any way to reduce the risk of that happening, and there's no way to predict who's going to happen too. But what I do is I tell adolescents, hey, you know, I tell them exactly what I just said about their chance that they could have that kind of bleeding pattern. And I say, please come back, please call. I really want to talk to you if you're not happy, because there are certain things that we can do to treat the bleeding. And I really like using OCPs to treat that bleeding. You can do a trial for 1 to 3 months. You can also do a high dose NSAID like ibuprofen 800 milligrams TID for 5 days to treat that bleeding. But no way to really prevent it. Yes, if you are inserting the implant not within the first 5 days after the first day of menses, then absolutely 7 days of backup. Same thing with 11 adjusterable IUDs. You want to say 7 days of backup. So the copper IUD works right away, but all of the other hormone methods, they need 7 days of backup if they're not inserted within the first 5 days after menses.
And school-based health centers?
And school-based health centers and IUDs. I have put IUDs in school-based health centers, and I'm very, very happy to be able to offer full range of contraceptive services. I think you have to work with your own organization and know your own kind of community culture to see if that's something that would be something that you all want to do. If you have specific questions or you want to talk about kind of how we did it, I'm really, really happy to have a conversation with you. And so if you want to put my email up on there, do you have it, Kevin? Or do you want me to say it? J.A. Robinson at unmmg.org. So I know that it's not always something that seems feasible in every community, but there are some guidelines out of either Oregon or Washington, and I can look it up, of other school-based health centers that have put IUDs in school-based health centers. And so I would just be really careful that you're not using a quick start policy for IUD insertion in school-based health centers, but also keep in mind that the copper IUD can be used as emergency contraception, which is different from a quick start protocol.
If I can add on to the school-based health center piece, I would encourage you to go to the New Mexico Alliance for School-Based Health Centers website, or the Alliance, as we affectionately call them. They are advocates for school-based health centers to insert LARCs, right? To be a place of service. And when we think more broadly about access for adolescents anyway, that is the spot-on place to do it, because those people are tuned into adolescent behavior. They offer safe, confidential environments, and it's a one point. I go to school, I go to the school-based health center, and then I'm set with a contraceptive of my choice. So we would really, I think, at Envision advocate for school-based health centers to be part of the delivery system for LARCs for teenagers. So that's my soapbox for the day.
Yeah, and I know that the Alliance has made a reproductive health toolkit for school-based health center providers, and they have that available. And we'd be happy to share that.
And Kim, who is the program manager at the Alliance, used to work in DOH's family planning program. So she's got the landscape in New Mexico and has really good ideas. If you're in a place where your school-based health center isn't, or your community is a little on the edge, they have ways to build the consensus, bring people together, and talk about what a valuable service this might be. So I encourage you to reach out to them if you just need some support in being able to deliver this very important contraceptive method to adolescent women at school-based health centers.
Yeah, totally. Did that answer all the points?
Sandra says thank you.
Oh, good.
Yep.
Any other questions out there in cyberspace?
Doesn't look that way. All right, well, before we wrap up, thank you, Jen, thank you, everyone. We have a survey, which I'll post the link for in the chat box, and you will also receive that link in an email. Your feedback is really important to us for these presentations, and it's only just a couple questions, just a couple minutes. Really appreciate it if you took the time to do that. I'll post that link in the chat box right now. And finally, just to repeat myself, if you would like credit for CE and ECU certificates, please announce yourself either in the chat box or verbally here on the phone, and I guess I better unmute everyone to receive those certificates. Just tell us what your full name is and where you're from. And I will go ahead and stop recording this meeting, and I'll leave the room open for a few minutes if anybody would like to discuss anything or if you have any additional questions.